Bismillahirrahmanirrahim. Today we will continue our CABI program with another funny case under title What Will Happen If the Reverse Word Acute Coronary Syndrome Meet Together, ACS and SCCA. Our case today is a female patient aged 67 years old, not diabetic, not hypertensive, but dyslipidemic. She presented at the emergency department with severe typical anginal pain, ECG showing ST segment elevation, myocardial infarction, and cardiac markers was positive. Bedside echo shows no segmental wall motion abnormalities. We transferred to the cath lab as soon as possible and starting doing non-culprit artery coronary angiography. I started by the right coronary artery, and as you see here, it is a quite healthy artery, and then I go to the left coronary system directly with a guiding catheter as to rapidly reperfuse the artery. But at the first time I using an XP guiding catheter, and as you see here in different projections I tried to delineate the ostium of the left main, but it was very unclear. And at different levels I start to doing a left coronary cuspogram, but nothing. So what is it, where it is, and how can I engage? So I start to ask myself, so if the artery is not present in the left coronary sinus, maybe it is arising from the right coronary sinus or the non-coronary cusp. So I go by the previous Judkin right diagnostic catheter with some modification of its tip curve by manual reshaping, and I start to navigating the right coronary cusp again. At this cine angiogram, as you see here, I start to make a non-selective injection, but near to the coronary right coronary artery ostium, and at that cine I start to observe an upright takeoff of a vessel. So I, by the help of the PCI guide wire, start to hook the guiding inside that vessel. The artery was going smooth. In different projections I start to delineate exactly what is it, but whatever it is, I observed an occlusion with a thrombotic lesion in that vessel. So I start directly to PTA. More and more the artery start to refill, but at that time I confirmed that it is an LAD artery. So I put a stent, and then I imaging it, and as you see here at that cine frame, I think there is an tachyarrhythmia that indicating a reperfusion with some grade TIMI 2 grade flow distally. This patient was taking glycoprotein to B3 for the next 24 hours, and she is doing well. So now we are facing the single coronary artery anomaly, which is a congenital anomaly defined as a solitary coronary artery arising from a single coronary ostium in the aortic trunk and supplying the whole heart. The incidence of single coronary artery is reported at 0.024% of the population, and there is no known gender predisposition. There is a well-known Lipton classification of this anomaly, which depends on three main parameters: the ostial location, which is right or left from sinus of valsalva, and the anatomical distribution of the single coronary artery, and the course of the transverse branch, either from the anterior to the large vessels or posteriorly to the large vessels, or in between the aorta and the pulmonary artery, and or in the septal course, finally, or a combined. In our case, after that we doing it coronary angiography and CT coronary angiography to delineate exactly the anatomical distribution and which type of this Lipton classification. And as we see, it is an R3 type, where the LCX artery has a course behind the aorta, while the LAD course anterior to the pulmonary artery, and there is a rudimentary septal branch seen as well. Finally, conclusion, acute coronary syndrome in single coronary artery is really a rare challenge as regard accessibility and emergency to reperfuse. Diagnostic catheters can be used efficiently to cannulate coronary anomalies with fine manual tip reshaping. Multi-slice CT coronary angiography is recommended to delineate such coronary anomalies. Measures of customizing the tools in our hands can efficiently make us resilient to shortage of our supply chain. And finally, thank you.